Good afternoon, everyone. This is Elizabeth Meeker, and I'm the Director of Training and Practice Transformation with Coordinated Care Services, and we are really pleased to be partnering with CTAC today to be bringing you the workshop on Trauma-Informed Care 101. And I'm here with my colleagues Gwen Olton and Cheryl Martin, who will be sharing a lot of information with us this afternoon. And this is the first of 6 sessions that are going to be around trauma-informed care. And it's been kind of our experience recently as we've been traveling and doing training across the state that I think we've really reached a tipping point where people have an awareness of trauma-informed and why it's important. And what we're hearing from people is that how do we take this and go deeper and deepen our practice in our day-to-day work. And so this series was really developed with that in mind and to really start to go deeper in a variety of different areas. So if you can go to the next slide, please. So just some logistics. If you want CEs, please log in under your own name. And if you are in a group, it will be important for you to email the list of attendees to ctac.info@nyu.edu, so that way they can have a record that you participated in the training today. We'll be going over the details of how to get the CEUs at the end of the session. So what we'd like to do to kick this off is really hear from you. So we'd like you to just take a moment and reflect and think, what makes this information on trauma and trauma-informed care important to you? So I'm just going to be quiet for a moment so we have an opportunity to reflect, and we will be reading aloud some of the responses. So just know that if you do choose to share that, it's something that we might be sharing out. Okay, so if you have something that you'd like that's on your mind and what makes this important to you, if you could put that in the chat box. So some of the things that people are responding is that the majority of people we serve have experienced some type of trauma, to gain more information to help our clients, to weave more trauma-informed language into policies, marketing materials, and other communication pieces, to not inadvertently re-traumatize someone. And so, I think as some of these responses are popping up here, we really can see that people have been thinking about this and it's on their mind, and obviously really want to have some ability to really be able to think about how to weave this into practice, both with clients directly, but also, thinking about how do we institutionalize this in terms of putting this into our policies and procedures, and communicating to consumers that we are trauma-informed, so thinking about marketing materials. So we hope that we'll be addressing this as we kind of continue on with the webinar. So I just want to take a moment just to kind of reflect for myself about why this is important, and then I'll be kicking it over to Cheryl and Gwen. But as I mentioned, that shift that we're seeing of the growing awareness of how important trauma-informed is. And becoming trauma-informed is the essential first step, but what we're really seeing is that people want to become trauma-responsive. So how do they take this? What does this mean for day-to-day practice? And so what can I do as an individual, you know, in my particular role in serving individuals, and then thinking about, you know, if you're a supervisor or a manager, what does that mean in terms of how you support your staff, and then taking it up to an organizational level. What do I need to do as an organization to make sure that we're trauma-informed, both for the people that we serve, but also for our staff? And so we see this webinar series as really a journey, starting with the foundation today, and then really thinking about the core values, which we'll be talking about, of trauma-informed care, thinking about safety and choice and collaboration, and restoring power and trustworthiness, and what does that really mean? What does that really look like within those different roles and relationships? Next slide. So our agenda today is the introductions, which we already did, and the welcome, which we also did. I'll welcome you again. And then we're going to be moving into the ACE study and thinking about how that, what that means, and then moving into a discussion of trauma-informed care. There will be opportunity for Q&A at the end, so if you have questions, please feel free to put those in the chat box. We'll be monitoring that throughout the webinar. So with that, I'm going to turn it over to Cheryl.
Thank you very much, and welcome everybody. In listening to Elizabeth, I've been contemplating just how far this has come since Dr. Felitti and Dr. Anda first thought about these issues way back in the 1990s. Something that at the time was not received particularly with any action. It just kind of came and went. Here we are today with all of this going on, where people are really starting to understand this and change. So back in the 90s, out of his own practice, Dr. Felitti began to notice that the folks that were in his obesity clinic, many of the women, were staying in the clinic for a while, losing some weight, and then leaving. And this really concerned him, and he had this intuition or this belief that there was something behind it, and started to ask questions and be very curious about it. And what he learned was that many of those women had histories of sexual abuse. This became a mission for him, and I understand he went to the CDC for a meeting and was not particularly received with enthusiasm in the beginning, but he did find a person who was very, very interested in that. Was Dr. Anda, who at the time was working at the CDC. Together they started to consider how they might measure this or figure out exactly what was going on, especially as it related to chronic disease. And the two of them put together the ACE study, which was a 10-question questionnaire that was asked of folks coming into the primary care offices of patients with Kaiser Permanente in the San Diego County area. They were patients that were age 18 and older, and they were asked these categories, which we'll go over in a little while. When they got the results, it wasn't what they expected. It was surprising to them, the extent of adverse childhood events. This was a population of working, private insured individuals in San Diego County, and the numbers were not what they expected. I will mention just as part of this that as more of this has happened around our country, but also around the world, this numbers come out fairly similarly no matter where you go. The thing that impacted me most, and I'll spend some time with that, one of the statistics, I spent 15 years working on an inpatient rehab for substance use disorders. And during that time, I felt there was a lot of things that were being done in the name of treatment that really were causing more harm than good, perhaps. And at the time, treatment was a bit confrontive, maybe a bit kind of minimizing it, was confrontive, and we've learned a lot since then. One of the statistics that are pieces of data that we got from the ACE study was that if a young man had 6 or more categories of ACEs, he had a 4,600% greater chance of being an IV drug user. That statistic for me, having considered the work that I did and the kinds of things that folks with addiction have experienced in their lives stopped me in my tracks and made me understand that, boy, this is really powerful stuff. And understanding that emotional abuse is one of the ACEs that seems to have a little bit more impact on people than any of the others. And here we are with these kinds of interventions for folks with substance abuse that kind of include a humiliation of sorts. So it got me on a track which said, learn more about this, understand more about this, figure out what you need to do to help the folks that have experienced these things and are now in treatment. So on that, I'm going to pass it over so we can talk about what's important to you around the ACEs.
So I know we already asked what's important to you about trauma or trauma-informed care, and now we'd like to hear a little bit from you. If one of our guesses when we're putting this together is that many of you probably already had some training in trauma or trauma-informed care. So we're really curious if there were statistics or data, some piece of information from the ACE study that when you first heard it, or maybe as you learned about it later on, that really impacted you, and if you wouldn't mind sharing that with others. That way we can kind of see, yeah, what's most important to us and what's impacted and resonated with us. So I'm going to give you a second to do that, and then we'll also share some more statistics that have been meaningful for us as well. We'll have our good friend Dr. Meeker read some of them if anyone pops up with some. And you can also feel free to Google some if you don't have the numbers right off the top of your head, or if you have a guess about it and you're not 100% sure, that's okay too. It's more about the meaning behind any of that data that you have heard before.
Okay. So looks like some of the things that people are aware of is that 2/3 of individuals indicated at least one ACE. This is someone also reported this is the first that they've heard of the ACE study.
Today is the first.
Yeah. The link between physical health and ACEs, brain changes after trauma and what it means for future functioning.
Great. Thank you, those of you who chatted in. And you can feel free to still share. I'm going to advance the slide a little bit and talk about some of the data that's been impactful to us. And also really helpful to know that some people may be hearing about the ACE study for the first time. So thank you for sharing that as well, because that helps us figure out where we need to go in terms of talking about it. So we did a pretty quick flyby of how the study was set up and where it came out of, but we're definitely going to dive a little bit deeper here. So if it's the first time you're hearing of it, fear not, we'll get you covered there too. So I'm going to, let Cheryl maybe talk a bit about the types of questions that were asked. You already alluded to one of them being that emotional abuse question. And we've got some of them up here. I think we might have 8, and there's 10 total.
Yeah, so I'll talk a little bit about that and then have you add to what's been happening in it now. So there were 10 categories. 3 of them were around abuse, physical, emotional, and sexual abuse. 2 of them were around, the word has completely gone out of my head now, neglect, physical and emotional neglect, incarceration of a family member, mental health disorder of a family member, substance use disorder of a family member, domestic violence or violence of any kind within the home, and then parental separation or divorce and loss of a parent. So that was what was originally done, but in the years since then, we've discovered that there's been a lot of other categories of toxic stress or trauma in childhood that really are impacting folks. So
Yeah, and there have been, as Cheryl had mentioned, this study's been repeated in other areas, asking more robust questions, having more than 10 questions, right? So you could spend a lot of time with the internet and researching all the ways that this study has been repeated over and over again. So some of the, so just to review, in case this is the first time you're hearing this information. So a couple of doctors who were researchers and clinicians got together, and they really were thinking, okay, sometimes we think that some of the things that have happened in people's youth are really impacting their health now, and not just their mental health, but their physical health. And we're seeing things played out in a way that we weren't expecting. So we're going to ask these 10 questions just to get a sense of, you know, if there's a correlation. And what they found was that there was a very strong correlation. And the folks at the CDC said that statistic that Cheryl gave you around IV drug users and people with more than 6 ACEs, gentlemen with more than 6 ACEs, that was the highest correlation of any study they'd ever seen, and that's the CDC. So it's a huge, huge deal. This was a really important study that was done in the 90s, and we're just hearing about now. I mean, many of us have known about it for a long time, but some of us are just hearing about it now, and it's not through any fault of our own, right? I think that well, we can have a lot of guesses about why this is, but one of them might be, it seems like a big thing to try to tackle.
There's probably financial reasons behind that, because what do you do? That's a lot of money. How do you prevent this? I think there's other issues about blaming of parents and that issue that we don't want to go there. And I totally am in concert with that, because this is something that isn't going to be helpful unless we partner with families so that we can really do something about turning this around.
Right, so she's not in concert with blaming parents, but with partnering with them.
I am not in concert with blaming parents.
Just to be clear. Right. So some of the statistics that we wanted to share that were pretty meaningful for us, or one of us, you know, when we were first hearing about it, which for me was just a couple years ago, and Cheryl's known about it for quite a while. So if you have an ACE of 4, or if one has an ACE of 4, and so we're going to be talking about risk here. You know, what is the risk? Not necessarily if you have this ACE score, then you're getting, you know, XYZ thing. So if you have an ACE of 4, you have 2 times the risk of cancer and heart disease, 2 times the risk of hepatitis and COPD, 4.5 times more likely to become depressed, and 12 times more likely to attempt suicide. So some of the statistics around suicide attempts especially were pretty stark. They're very high correlations, a very direct relationship, and dose-dependent relationship, right? So the higher the number of ACEs, the higher your risk. So if you have an ACE of 5, you may have 8 times the risk of alcoholism. 6 or more will, and if you look at the slide here of this pyramid, one of the things that it says right at the top, if you can't quite read it, it says early death. So what the researchers found is that you have 6 or more ACEs, you have a greater risk of up to 20 years reduction in your life expectancy. So again, just a really high correlation that they found that was surprising to them.
In thinking about the suicide rate, also depression was very highly related to this. So, you know, you look at this and you think to yourself, wow, I mean, we focus on these sequelae that happen down the road, the substance use, the homelessness, the maybe engaging some social things like prostitution, that kind of thing, and yet this is all going back to this one issue. And it covers all of our public health issues that we talk about, our physical health issues, our mental health issues, our addiction. In fact, to the point that one psychologist mentioned that if we could do something about this, the DSM-5 would be the size of a pamphlet. This is a powerful thing in the work that we do, especially with chronic issues, both socially, physically, and emotionally.
So we threw a lot of statistics at you, and we have other resources both at the end of this PowerPoint, and perhaps we've chatted some in, but we'll have, when you look at the end of the PowerPoint, you'll be able to see some of the resources where if you're wanting some more information just to read up a little bit more or find out more of those statistics around your health risks, we've got that for you. So thinking a little bit about how this happens, how we climb up the pyramid of risk, first we really kind of need to understand a bit about what trauma is. I'm going to let you talk about that a little bit, I think.
So there's the 3 E's of trauma. There is an event, and that is an exposure to an event or a series of events, as you see, that threatens the well-being of the individual. One very important thing about this is that no two people are the same. So an event for one person may have very different meaning and effect than that same event for someone else. So, but it's very important. Something happens, right? Something happens, and it can either be that single thing or a number of events on top of one another. The next piece is that experience. So that is the piece I just mentioned about how does that person respond to it? In other words, is it something that creates fear in them, that sense of helplessness, the sense that they can't get out of it, that it may happen again, that whole horrible feeling that really comes from being exposed to the trauma, whichever single event or series of events. And then what does that do to us? And this is more about the piece that folks mentioned with the brain. How does it affect our brain? How does it affect the wiring in our brain, the way we think, the way we view the world? Perhaps, you know, the number of times it happens to us can have an impact on how that's going to affect us. A one-time incident may not have the same effect as repeated incidents or being in that state of always expecting something again. But that's the thing that's important to understand is that the actual structure of the brain changes. And in a way that's important because it helps the person survive, but in a way that does have long-lasting effects for the person around their feeling of being safe in our community or in their family or wherever they happen to be, and an understanding that that there's an ability to trust other human beings. Yeah.
So if we're thinking about what some of these events look like in our body, right? Like in the moment, we can think about it as something that you're probably familiar with, right? Fight, flight, freeze. So something triggers this response in us, and we have very little control over this sort of trigger, right? So maybe we see something that we think is dangerous, like a snake, and we have some, we've used the snake example before. That is that knowing look. So, you know, we see a snake and we have a fear response to it. So we have part of our brain, and there's more than just this going on, but our hypothalamus gets triggered that there might be something going on, and it sends a signal to our pituitary gland, and our pituitary gland sends the signal to our adrenal glands, and all of them are saying, danger, we have to get ready to fight or run or hold very still so that we don't get eaten or killed or whatever, right? So this is a very wonderful adaptive thing that our bodies have developed to keep us safe. So what happens is when it gets triggered over and over and over again, the hormones that are released that help you fight, flight, or freeze become unhelpful to you in your day-to-day activities. So we know that long-term exposure to things like cortisol and adrenaline, they end up having really rough effects on your body, and that's part of why we see all these poor health outcomes or high risk of poor health outcomes with repeat toxic stress and trauma.
Yeah, we want to recognize that we'll be looking a lot at resilience, but they have done some things looking at folks, women particularly postmenopausal, and looked at their cortisol levels, and there was a connection, a relationship between the amount of exposure to ACEs they had as children and their cortisol levels, even at the age of 60 plus, which is pretty remarkable to think about how impactful that was, which also makes it more important for the things we're going to talk about, which is resilience and later on.
And some others, yeah. So just, you know, a quick model of the brain. Won't spend too much time here, but when that fight, flight, freeze response is triggered in us, one way, very simplified, and in some ways, you know, it's not the whole picture, right? But a simple way to think about the brain would be the reptilian brain. This is the oldest part of our brain, develops first. and is very quick to respond. It controls things like our impulses and our reactivity. Yeah.
And we are not conscious of that.
Right. We don't get to control much that goes there, right? So it controls our breathing, things like that. And it speaks very quickly and easily to our emotional brain, our limbic brain. So some of where and how our memories are stored, some of how we emotionally relate to an experience. These two parts of the brain speak to each other really quickly. And when a triggering event, either because of trauma or because of danger being around or whatever it is that might trigger us, they have a very quick pathway to talk to each other to help keep us safe. But the tricky thing is when we are in that place, when we're being triggered or something is happening to us where our bodies have a fear response or an anger response coming out of fear, et cetera, we don't have great access to our frontal cortex, or the thinking part of our brain. We even have decreased blood flow there. It is just really tough for us to get to that part of our brain. And we've all experienced this to some extent, even if we've just been a little upset and maybe you heard advice from a parent or a caregiver when you were young not to speak out of anger or not to try to solve problems when you were really upset. And it makes a lot of sense because we don't reason real well when we're upset. It's tough to get over even to that part of our brain.
It's also important to understand the development of the frontal cortex too, and to understand that it doesn't have the same level of development in very young children, and that this is something that can create some issues around their life in school and that kind of thing, where they need that support from others to be able to have some control over that fight, flight, or freeze response. So
yeah, I'm glad you mentioned the piece about the youth, because we know as well that they are more susceptible to the harmful effects of repeated exposure to stress hormones because their brain is supposed to be in a growth state at the time. It's the same reason they actually are more susceptible to routing addictions when they're younger. Yeah. Mm-hmm. So one of the things that we talk about, because there's been some really exciting research, and I think we'll at the end of our PowerPoint we have a link to Rachel Yehuda, but there are other researchers, Bethel Vanderkoop, and lots of others who have researched resiliency and saying, okay, so we know these tough things happen to people. How is it that they're able to survive and thrive? So Rachel Yehuda had this great analogy talking about resiliency, so and thinking about genetics and epigenetics. So there's a lot of exciting research, some of it controversial, some of it just very new and needs to be fleshed out more, but still pretty interesting to think about.
Yeah, I think maybe we could talk about it just for a minute.
Yeah.
So when it comes to our genetics, we're all aware that we get that little piece from dad and that little piece from mom, and those are the genes we're given. That doesn't change. But what we've been learning is that those genes get turned on or turned off very early. In fact, during their time in utero, it can start based on the amount of toxic stress and other environmental issues that people are exposed to, right from prenatal time, even to the point that those changes, the epigenetic changes, which they're called, in the wiring in the brain that have happened generations before, can impact us 3-4 generations down the road. So I think that's important stuff to know, because one thing that I care about a lot and believe in a lot is that how you view the people in front of you when you're working with them will have everything to do with how you treat them. And there's a humility that comes with understanding that a lot of what we bring has been given to us long before we're even really conscious of our behavior and how we're going to deal with it. So I think that's a really important thing to understand. Yeah, something I want to share. So I'll leave you to this wonderful, I love this metaphor.
So a couple of the studies that were done looked at, one example of it was looking at granddaughters of women who have survived famine. And what they found was that there were some epigenetic changes that happened. So things in genes were switched on to say, hey, if you are around food, you should eat it because we are in a starvation mode. So anytime you see some food, we need to make sure that's ours. So that was essentially the messaging that was epigenetically coded. And then what researchers found were in the granddaughters of women who had survived these famines, they still had that gene, that gene turned on. They still had these epigenetic changes, and it was resulting in obesity for a lot of women, very predominantly, and that they still had these epigenetic changes turned on to help them survive a famine that was no longer around. So now they were living in a place of abundant food, and it was no longer adaptive. It had become a maladaptive change. So her analogy for this happening is if you think about having a smartphone, right? So if you have an Android phone, for instance, the system that you have on it, your operating system, you have an Android operating system on your phone, that would be like your genetics. So you kind of get what you get out of the package. Unless you do some crazy things, you can't really change anything about that. You get what you get in terms of your operating system. So same with your genes, you sort of get what you get, right? So they're not a perfect analogy, you can unlock your phone anyway. But then your body can make these changes. So on your phone, if for instance I'm struggling to navigate around a city, I might add an Google Maps. I might add an application. So I add that app so that I can do things. And then if my phone breaks and I go to my cell service and I go to get a new phone, all the apps that I downloaded on my old phone will automatically come onto my new phone unless I take them off. So it's sort of a simple analogy to think about genetics and epigenetics. So genetics are like your operating system, and your epigenetics are like the apps that can be added or taken away depending on your need. And those apps stay generation to generation unless unless there's an intervention to change it, essentially.
Yeah. One of the circumstances that somebody had shared with me one time was about it being pregnant, for instance, and living in domestic violence. And a young woman had come to her and said, well, once the baby's born and he or she is old enough to understand what's going on, I'm going to do something about this. And I think this really tells us that if it's happening right from the beginning, that's probably too late. And so it does have an influence on how we might speak to people and understand exactly how impactful our environment is to us, even in that very early prenatal time.
Right, so not too late to do anything,
no,
but that it might be too late for some of the epigenetic changes that might be caused by high increase in stress hormones.
Never too late to do something.
Right.
Right.
I just want to jump in. There's some questions about the term that you're using, epigenetic. So some people are having difficulty even knowing what the word is, and so if you just could spend a moment just enunciating it and also defining it, that would be helpful.
So I want to apologize that I have some gear in my mouth that make it difficult for me to say some of these words, so it might be my fault and I apologize. But I'll let Cheryl.
It's spelled epigenetics, epigenetics. And when I mentioned in the beginning that we get this little piece of genetic stuff from our dad and this piece from our mom, what's happening is that certain things, environmental is quite broad too. It can be those things in our environment like maybe poisons or things like that, but it also is about what happens to us. So it might be, as I said, maybe mother is exposed to domestic violence, so what does that do to her body? Raises her level, all of her stress hormones. And what does that do to the infant's brain while the baby is not yet born? Raises all of theirs. So what does that do? It goes to those genes, and some genes get turned on and some get turned off. So it impacts those genes. Just because they're there doesn't mean that they are all going to be active in our process of development and who we become. So that's really what's happening. This is why we can look at some people have a gene that may predispose you to a certain disease, And yet, if that never gets activated, you never get the disease. So folks in a family, 2 or 3 people might have that gene, but not everybody gets the disease. So that's what that is about. So I hope that's more
yeah, there's certainly, you know, longer, more complicated explanations that are out there than we're giving. So we are giving a simplistic form of it, and I don't think we particularly have it. Besides Rachel Yuhu's work, we don't have anything too intense about genetics or epigenetics in our links. But if it's something you're really curious about, you can let us know, and we can look into it more for you. So just thinking a little bit about why would this information matter? So our guess as to why it matters, or some of why it matters to us, is that you know, we really firmly believe that understanding the impact that trauma has on folks changes our interpretation of the people that we're serving or the people that we're interacting with day to day. So knowing that, knowing these risk factors, knowing that there are many, many people who have experienced trauma, knowing that I'm both serving and working with and for people who may have experienced trauma, it changes the way that you might interpret some of the things that you see or interpret other people's behavior. And that change in interpretation impacts how we talk with other people. It impacts our tone, our body language, our facial expressions, even if it doesn't impact our words. And all of these have huge amounts of meaning. It's a big part of how we convey meaning, are all these you know, nonverbal cues about our interpretations of other people. We all know pretty well and pretty intuitively if someone is judging us or angry with us or thinks less of us, right? So we can see these things on people's faces. You can recognize someone's face with 20/20 vision from across the football field. We can see facial recognition. So we're all highly attuned to what other people's faces and body language are doing. So that's not the only reason we think it's important, but it's a big part of how we can change things.
It goes back to what I said, how we view that person. And I think it's important to recognize, too, that we're talking that with folks that have had significant trauma, they are going to be more alert to that because they need to survive or have needed to. So it becomes even more crucial that we understand how that impacts them.
So I'm just going to think a little bit about information you might have of something that's going on. So maybe you're instructing a classroom, for instance, right? And you have a youth in front of you, and you give them a direction to turn in their homework, for instance, something like that. And you have a reaction that maybe to you seems over the top. So maybe they flip their desk and scream no and stomp out of the room. So something sort of big. So one interpretation of that behavior might be, well, they're defiant, they're oppositional, they're not complying with what I want. Another interpretation of the same behavior might be they really value their autonomy. They really don't want me telling them what to do. Maybe they feel unsafe. Maybe they're in fight mode. So we have these under interpretation be as being may and maybe because we don't know. And I think you can see that under the interpretation in interpretation A, it's sort of a hard stop. When we label someone with a fierce judgment like that, it cuts off conversation for us internally, and it cuts it off externally too. So interpretation B is a little bit more curious and a little bit more open. And that's kind of where we like to move to, I think. We do anyway.
And you've talked about it with children, but I think about it in medicine too. That word non-compliant gets used a lot, resistant, unmotivated. And I think that's really important to think about. People have a right to their autonomy. How can you be non-compliant when you have every right to choose what you do around your own health care? How can you be resistant when, again, you have that right to make a decision about what it is you're going to do and what you're not going to do? Unmotivated, particularly loaded, because if people are getting out of bed and eating their breakfast and doing things, they certainly are motivated. And usually unmotivated means more accurately, they won't do what I want them to do. So it's important to think about how we use those words. You mentioned that before, that words are, I want to understand language that can make a difference. And I think we've done some modeling of that. I called it substance use disorders and not substance abuse. I do that purposely. because the word abuse has really strong, big kind of message with it in our society, and I don't want to use it for the person that I'm going to be working with in front of me.
So we're going to, in the interest of time, move on to our next section here. So what is trauma-informed care? So we've talked about trauma, we talked about the ACE study. So what is trauma-informed care, and how does all this information fit into that?
Can we ask one question, Elizabeth? And are there any questions about the stuff that we've already talked about that we haven't addressed before we move into what does this mean around trauma-informed care?
I think you can keep going.
Yeah,
there's some things we can catch at the end.
Okay.
Thank you for asking.
So we have a couple, there are definitions that are out there from SAMHSA. We have a number of ways that we can define it. So a couple ways that we're thinking about it, are that trauma-informed care is a way of delivering services or a way of interacting with people in the world that takes into consideration the significant impact violence and trauma have on people. It could be individuals, families, communities, the world, so you can kind of bring this out to as large of a scope as you want. And another way to think about it might really be, and I think maybe a more robust, fuller way of looking at it is that it's really a worldview shift that happens when you allow the knowledge of trauma's impact to impact you, to shape your thoughts and beliefs and actions.
Mm-hmm. It's really a humanistic way of being, not just with those who've experienced trauma, but everyone. Yeah. Way of living.
So we say there are 5, and SAMHSA says, and other people say there are 5 core principles of trauma-informed care, and these are safety, choice, collaboration, trust, and empowerment or power restoration. And I'll let Cheryl talk about why we say restoring power and not empowerment here.
I started to realize that when we say the word empowerment, and not just me, but others have too, that it sounds as if we have something to do with giving people their power. And the reality is they always had it. And folks with histories of trauma often don't know that they have that power. And often systems and programs and things that they lived in the community have said, kind of reinforced with them, you don't have power. So we really just want to get out of the way and have them realize the power they've always had. And I think it's important to talk about these too, that they overlap. I mean, they aren't.
Yeah, they're not very separate, really.
Not really. So collaboration suggests that we each have power and that we share our power together, and obviously the person who's making the decisions or receiving the care gets to decide what ultimately they want to do. So in collaboration, there's a lot of choice. Mm-hmm. When you talk about safety and trust, those two things would have to be there in a collaborative conversation. Restoring power, you are treating the person in front of you, and I use this term a lot, they are the expert about themselves. They are the expert about them and their diabetes. They are the expert about them and their addiction. They're the expert about them and whatever other social issue they may have. We can never be the expert about them and that issue. They will be that person. So that kind of focusing and understanding that they have as much to offer to this conversation as we have perhaps in our expertise as professionals.
Yeah. So what we have for the next slides that you'll get are looking at each of these principles and thinking, okay, what are some examples of consistent, trauma-informed consistent ways to approach something versus some inconsistent ways? Because I think it can be a little helpful to think about how this looks on the ground, because otherwise these might seem sort of nebulous kinds of principles, or they sound like a great idea, but it doesn't necessarily translate to work. So I think what we'll do, because it's 12:45, is we'll look at one, maybe two, depending on how long it takes us to get through one of them, going through the example. That way we leave, a good 10 minutes or so for questions. Okay, so we'll look at safety first. So if we're thinking about, I'm going to go through some of these bullets. So this could be in multiple settings, but maybe you overhear staff speaking about service recipients to one another. And we would think about that being inconsistent with safety because it might not be consistent with your emotional safety. So maybe you don't hear that if I'm a service recipient and I hear that happening, they might not be talking about me, but then I have lower trust that my confidentiality is important to anyone other than me. I might feel emotionally unsafe to share information with the staff, so it can change the way that you view emotional safety. So a consistent way to approach that would be for information to be shared only on a need-to-know basis and with respect. So some of this, I mean, I've worked in places where it was frequent for service recipients to overhear staff talking because staff didn't have confidential places to speak, and it was important that they share information. So some of it sometimes is just about building the structures or the time for people to share information.
Yeah. And even when we're just there in a private place with each other as staff, it's important that whatever we're saying could be heard by that person that we're serving. In other words, spoken about the same way that you would if they were sitting there. I think that's a very important thing because that's going to impact how we go out and do our work as well.
Right, and I think that goes back to thinking about how are we interpreting what's going on for people. So I certainly would hope to live my life so that I say things behind closed doors that I would say in front of people, right? So I want to be consistent and authentic enough and compassionate enough with the way that I interact so that those things can align. And one way to do that is to make sure I'm keeping this trauma-informed approach because it changes how I'm interpreting what's going on. So. And then another example of inconsistent might be that physical aggression is dealt with on an ad hoc basis. So it comes up, we just deal with it in the moment. And I see this happen frequently with schools. So we work with a number of school districts, and there might not be a lot of proactive safety planning around physical aggression. So they might see a rise in physical aggression, and then teachers or other people participating in school staff support might feel really unsafe because there just isn't a consistent plan to handle physical aggression. So a consistent way might be clear planning created by all stakeholders, so including the youth who might have a history of physical aggression, helping everyone plan together, okay, when we're really triggered and we might move to physical aggression, what are some ways that we can de-escalate? How are we going to approach this issue altogether?
And it forces us to look at some of the practices we have, especially when you think about psychiatric services and restraining people or putting them in isolation. There are things that we can look at to enhance the safety for them, the feeling of trust that they're not going to be abused in any kind of way. So it becomes hugely important that we are proactive about this, that we understand what it is and we know how we're going to work together as a team, that we are ready for that, right, in a way that isn't traumatic.
Right. And then the last one on here has to do with physical safety, and I usually only touch on this a little bit. I think partly because it's the sort of easiest thing to think about, and usually people's physical safety is attended to when there's a culture of safety. So it becomes less of an issue when you've addressed the other things. But things that can contribute to feeling unsafe at work or in places where you're receiving services might be having unlit parking lots when you have to have meetings at night, for instance, or having service delivery sites that are unclean feeling or seem dangerous in some way.
I think it's important to note that you've talked about this safety along the full continuum too, for the people we serve, but also for the staff that work there and anyone else that might have to, interact in that particular with that staff. I think that's really important to understand because it needs to be at all levels for us to be able to have the outcomes that we're looking for.
Right. I'm glad you brought that up because I meant to touch on it when we first looked at possible definitions for trauma-informed care, in that we can't be trauma-informed just to the people that we serve. So if I'm nursing and I'm working in a pediatric setting, I won't really be operating under a trauma-informed approach if I'm only being trauma-informed to the youth that I work with, but I'm really inconsistent with a trauma-informed approach with my coworkers or the doctors that I work with, et cetera. So we can only be trauma-informed to service recipients really to the extent that we are giving and receiving that trauma-informed approach. And I'm sure you've heard this with other sorts of things, right? We can only care about others as much as we can care for ourselves, and and vice versa. So I think that we intuitively know that we have to have some of this safety for ourselves in order to create a culture of safety for others. We have to have some of this choice for ourselves in order to create a culture of choice for others.
Yeah. And understanding the prevalence of trauma, many of our co-workers and people we work with out in the community are going to have those same trauma experiences themselves. So it isn't just the people we serve.
Right. So with that, I'm going to stop going through these slides. So we do this, we've got this sort of consistent and inconsistent approach through the rest of the principles that you can peruse at your leisure. I think we'll just open it up maybe to any thoughts or questions that you might have.
Yeah, so please feel free to put any questions or thoughts you have in the chat box. There were a few questions that have come up along the way that while people are typing in, I thought that we could quickly address. So there was a question about the original ACE study and in terms of demographics. And as was said, the majority of participants in the original study were Caucasian. That was 75%. Specifically was asked around African Americans, and that was about 4.5% of the participants. However, as Cheryl mentioned, the study's been repeated with many different populations across the country and across actually the globe, and the results come back very, very similar over and over again, regardless of kind of the demographic background of individuals. There has another kind of question that kind of relates to this around the ACEs was around, are the ACEs questions the same for each group? And so the set of ACE questions have been consistent. However, some groups have added what sometimes are referred to as urban ACEs, so looking at exposure to things like community violence and that sort of thing. So some people have kind of expanded the ACEs because, as was mentioned, that's one set of trauma that someone can experience, those types of really interpersonal traumas, but people experience other types of trauma as well. So let's take a look to see what other kind of questions has come in. So one person asked, what can we say about epigenetics and historical trauma while working with diverse populations in healthcare? What should providers remain mindful of?
Yes. The impact of the things that our parents, our grandparents, our great-great-grandparents going back does impact who we are today as a person. So that's an important thing to understand. I've heard people say things like, well, that happened generations ago, it shouldn't have any impact today. Well, this just is not true. It is not true. What happened a long time ago can continue to impact us in our families and in our communities for many years. And really, I always think the first step of this, and I think the most important step, is just that acknowledgement and awareness of the history and the trauma that's happened.
And I just want to add that there are a number of researchers that do work specifically on historical trauma and specifically in the African American experience that will speak to this more and better than we will, right? So Joy DeCruz has a book called Post-Traumatic Slave Syndrome that I would highly recommend. And to answer the question of how would we talk to people that we're providing services to about their trauma, on the one hand, it's really good to be transparent. On the other hand, it can be really easy to try to tell someone that they have trauma, right? And we don't know that that's true. We also don't know how that will land with folks. So we have to use our intuition and our sense about what will be helpful and won't, because it can be really easy to fall into an instructive sort of dynamic, telling people about their experience, and that's not helpful and probably will turn them off. So just want to mention that, even though I doubt that's what the questioner was getting at, I just think it's important to kind of know.
Yeah, our knowing is really important, but I think when we're working with people, the most important thing is our curiosity in a kind and compassionate and caring way, that we do more listening than talking. that we try to understand everything from their perspective, because no matter what our experience is, it's never going to be the very same as the person in front of us. And most of what human beings tend to do is to run their behaviors based on their own perspective. We need to learn what their perspective and experience is, so that if they bring up that issue and it's theirs, now we have somewhere to go in the conversation. They will be the expert about their own experience and their own thoughts about historical trauma. I think that's what keeps us in a safe place.
Yeah, I think the curiosity too, right? So we're seeing a lot of health outcomes that may indicate, you know, some of the risk factors for an ACE. We can ask people about their experiences in a way that's very open and curious. So I'm wondering what your health outcomes are meaning to you. I'm wondering how this information is landing with you. I'm wondering what your ideas are for where these health outcomes come from. So I realize we only have a few minutes left. I want to see if there's another question, but also I think we needed to go over the CE credits again. So.
Okay, right.
Could you repeat the name of the book, the slave book? I have a few people asking for the author again.
So, post-traumatic slave syndrome, and I'm going to spell it so that
Write it at the same time.
And the author's last name is capital D-E, capital G-R-U-Y. And her first name is Joy, J-O-Y. There's a lot of hard J sounds in there that I cannot enunciate right now. I'm sorry.
So there were some additional questions, and we can look for ways to respond to those and maybe share that information out. But I do want to make sure just to go over how you can obtain your CEU information. So first, make sure that you have signed on as an individual. If you are in a group situation listening to this webinar, please send an email with the participants who are in attendance to ctac.info@nyu.edu. So you can see the steps that you need to take here. You need to create a username and password, and then log on to the Continuing Education Online portal there and click on the All Events and Program tab, and then scroll down to select today's webinar under Online Learning. Click Register, and then fill in the billing information, click Register, and pay the registration fee. So when the slides become available too, you can reference this slide in order to get those CEUs. Go to the next slide. So again, here's some additional information in terms of registering and getting that information. And there's information here too about if you need additional assistance, where you can go for a number to call or the email. So if you have any problems with that, please feel free to reach out, and we can offer some assistance to make sure you get those CEUs. Here are some additional resources. So for those who are interested, and I know there were some more questions about the ACE studies and where is good resources for accurate information and statistics. So I would highly recommend the resources that are on here. The other thing is there was a question about how to explain this information about trauma and its impact to the people you serve in a way that's kind of very friendly and not a science lesson. So I would highly recommend the hand model of the brain, and that's Dan Siegel's work, and he's very accessible and explains the brain in a way that you know, anyone can understand. I think Cheryl's just modeling the hand model of the brain for us and flipping our lid. So watch that. It's something you could watch with a client and talk about, and in kind of a fun and easy way to kind of understand what's happening. Here's our contact information. We'd love to hear from you. So if you have additional questions, follow-up, please feel free to email or contact us directly and see how we could be of assistance. And here's the rest of the series that is coming up, so please register if you haven't registered. And what we'll be doing is some of the things that we talked about at a high level today we'll be going over in more depth, and upcoming training through CTAC as well, the next one on June 1st. So we want to really thank you for your time and attention today, and look forward to future conversations.
Bye. Bye. Yes.